The only reason to extract the third molar in an older compromised patient is pathology. Most common complication of extraction, root fracture. Patient has pain and drainage a few weeks following extraction. What is your diagnosis? Osteomyelitis. More recent pain would probably be dry socket, but um, if the pain persists long after the extraction, it's osteomyelitis. How to treat post-extraction osteomyelitis? Clean socket walls with curettage to remove infection. May also need antibiotics and drainage. If you need a root, if you get a root fracture during extraction, what do? Control bleeding and visualize root tip. In what direction do you luxate? You luxate vestibularly in adults and palatally in children. If a patient is on IV bisphosphonates, if a patient, yes it is, but I'm not going to take it because I already. If a patient is on IV bisphosphonates or radiotherapy but needs full mouth extractions, what do? Do endo, then remove the crowns of the teeth. So you minimize the exposure of bone. What if you really have to do extraction in a patient with osteonecrosis or IV bisphosphonates? Give hyperbaric oxygen therapy. Hyperbaric oxygen therapy. What is the number 23 cow horn used for? Maxillary molars. I mean mandibular molars. What is the 74 ash forceps used for? Mandibular premolars. What is the 88 right and left cow horns used for? Maxillary molars. 88 right and left cow horns used for maxillary molars. What are the 151A forceps used for? Premolars, mandibular premolars. What is the 65 bayonet forceps? Maxillary incisors or root tips? 65 bayonet forceps. 65 bayonet forceps. And they look like this. Oh. What is the 65 bayonet forceps used for? Maxillary incisors and root tips. What are the number 151A forceps used for? Mandibular premolars. What are the number 88 right and left cow horns used for? Maxillary molars. What are the 74 ash forceps used for? Mandibular premolars. What is the number 23 cow horn used for? Mandibular molars. What if you really have to extract a tooth on a patient with osteonecrosis or IV bisphosphonates? You recommend an hyperbaric oxygen therapy. If a patient is on IV bisphosphonates or radiotherapy but needs full mouth extractions, what can you do? You can do endo, then remove the crowns of the teeth. In what direction do you luxate? In children, you luxate palatally. In adults, you luxate facially or buccally. If you get a root fracture during extraction, what do? Hemostasis and visualize the root tip. How to treat post-extraction osteomyelitis? Clean socket walls with curettage to remove infection. May also need antibiotics and drainage. Patient has patient has pain and drainage a few weeks after following extraction. What is your diagnosis? Osteomyelitis. If there was more recent pain, it would probably be dry socket, but if the pain persists long after extraction, it's osteomyelitis. What is the most common complication of extraction? A root fracture. Crier elevators are best for single retained roots of mandibular molars. Number 150 maxillary molars. Number 151 universal mandibular molars. What does Medicaid cover? Extractions, one complete denture, and children under 18. Biggest risk when extracting a lone maxillary molar? Fracture of the tuberosity. Lone molars are often ankylosed. Treatment for oroantral communication of less than 2 millimeters, you don't do nothing. If there's a communication of 4 millimeters or oroantral communication, you do antibiotics, nasal decongestant, and figure 8 suture. That's a treatment for oroantral communication of 4 millimeters. If you have an oroantral communication of 6 or more millimeters, you do flap surgery. What is the Caldwell-Luck technique used for? It is an incision that gives you access to the maxillary sinuses, and that is used to retrieve root roots that have been uh, lodged, that are in the maxillary sinus. Suture to place when only buccal tissue is displaced, interrupted. Suture to place when only buccal tissue is displaced, interrupted. Tissue Suture to place when only buccal tissue is displaced, interrupted. Type of suture that contains wicks and allows bacterial invasion, silk. Correct way to place sutures in tissue, you go from movable to non-movable. Three types of periodontal flap. Modified Whitman flap, the undisplaced flap, the apically placed flap. These are three types of periodontal flaps. Modified Whitman flap, what is its purpose? Access for instrumentation, not pocket depth reduction, but it does remove pocket lining. So, access for instrumentation, not pocket depth reduction, but it does remove pocket lining. Modified Whitman flap. Undisplaced flap purpose, pocket depth reduction. What is the purpose of the apically placed flap? Pocket elimination and or an increase of the width of the attached gingiva. What is a contraindicated location for apically positioned flap? The maxillary palate is a contraindicated location. You will not do an apically positioned flap on a palate. With the least desirable location for a gingival graft, the maxillary premolar, first premolar, least desirable location for a gingival graft. Where to avoid vertical releasing incisions, lingual and palatal. Avoid vertical releasing incisions. Why? Vertical releasing incisions, here they are. vertical release and incisions, you will not do these incisions. And by the way, you will not go right there or right there. You have to go here. Okay, so you will not do those incisions in palate or lingual. Vertical incisions are avoided in the lingual or palatal areas. Facial vertical incisions should not be made in the center of an interdental papilla or over the radicular surface of a tooth. Type of bevel used in modified Whitman flap. It's an internal bevel, replaced flap. Do not reflect flap beyond the mucogingival junction. Type of bevel used in modified Whitman flap. Internal bevel, replaced flap. Do not reflect flap beyond mucogingival junction. Flap design for removal of palatal torus, double Y incision with midline incision and arms anterior and posterior. Contraindication for distal wedge flap, third molar area without attached gingiva. Distal wedge flap contraindications, third molar without attached gingiva. Gingivectomy indications: gingival hyperplasia, suprabony pocket, and suprabony abscess. You can do a gingivectomy indications. The contraindications are going to be the opposite, infrabony pockets. Okay, if the pockets are below the bone edge. Aesthetics, if doing a gingivectomy will damage the aesthetics. Inadequate attached gingiva, if you have inadequate attached gingiva, you will not do gingivectomy. Osseous recontouring, okay, you will not do a gingivectomy if there's osseous recontouring. A base of pocket is apical to the mucogingival junction. If the base of the pocket is apical to the mucogingival junction, you cannot do a gingivectomy. Type of bevel and healing in a gingivectomy: external bevel, healing by secondary intention. Main function of a periodontal surgical dressing: protect the wound. This will not accelerate the healing. Different types of healing and examples. Different types of healing and examples. Repair, e.g. long junctional epithelium. And okay, the type of healing is repair, like e.g. long junctional epithelium, and regeneration, which is in periodontal ligament and bone and cementum. So a healing that regenerates is periodontal ligament, bone, and cementum. A healing that is just repair is a long junctional epithelium. Okay? So long junctional epithelium can repair, and just cementum, bone, and periodontal ligament can be only regenerate. Most common post-extraction complication: dry socket or alveolar osteitis. Big risk factor in getting dry socket: smoking. What causes a dry socket? Fibrinolysis or dislodgement of the blood clot. Symptoms of alveolar osteitis: pain, bad taste in mouth, bad breath. Treatment for a dry socket: gently irrigate, place a medicinal dressing, which is zinc oxide with eugenol. No antibiotics needed. Don't curette. Osteomyelitis, you do curette, you use antibiotics. With this, you don't need to curette. You only irrigate. Common types of trauma to teeth: avulsion, in which the tooth is knocked out, intrusion, lateral luxation, and fracture. Sign sign of a mandible fracture. Signs of a mandible fracture, you'll see changes in occlusion. Condylar fracture complication with growth of mandible. Injured site will lag in growth, resulting in facial asymmetry. So if you have condylar fracture, what is going to be one complication that is related with growth of the mandible? In this complication, the injured site will lag in growth, and this will result in a facial asymmetry. Splinting time for a closed bone fracture, 6 weeks. 6 weeks. Paresthesia, e.g. lower lip numbness, is most common in what kind of mandibular fracture? Paresthesia is most common in what kind of mandibular fracture? A paresthesia will be most common in a angle fracture. Why? Because if you have condylar fracture, you will not have paresthesia because the nerve is usually comes out lower. Okay, and I mean goes in lower. So at the angle of the mandible, the bone is already, the nerve is already inside the bone. So if you break it right there, you will have paresthesia. If you break it in the symphysis, the nerve is already out in the foramen, mental foramen. A Lefort fracture involves the maxillary sinus. Lefort fracture 1 involves maxillary sinus. The Weiring sign, which is ecchymosis of the greater palatal vessels, is a sign of what kind of fracture? Lefort 1. Lefort 1 is known as floating palate, or you will have floating palate, you will have malocclusion and crepitation in upper buccal sulcus. In Lefort 2 fracture symptoms, you will have separation and mobility of the midface, anterior open bite, periorbital ecchymosis, diplopia, subconjunctival hemorrhage, infraorbital nerve damage, Lefort 2. Now Lefort 3 is a craniofacial separation, cerebral spinal fluid rhinorrhea. Most common fracture of the face, nasal bone, then the zygomatic bone. At what age does the mandibular symphysis fuse? 6 to 9 months. At what age does the mandibular symphysis fuse? 6 to 9 months. A punch to the right side of the face will most likely fracture which condyle? The left condyle. A fracture of the left body of the mandible is likely accompanied by a broken right condyle. Most and least common areas of mandible fracture, the first one is the condyle, the second the ramus, and then the least one is the coronary process. What is the best X-ray to determine horizontal fracture? Best ray to determine horizontal fracture? Well, multiple vertical angulated radiographs. Best X-ray to view the zygomatic fracture? Submintovertex. Best X-ray to see maxillary sinuses and midfacial fractures? Waters view. Waters view is for maxillary sinus and midfacial fractures. Best X-ray to view mandible fractures in general? Panoramic. Best X-ray for condyle fracture? Reverse Townes view. Reverse Townes view is best for viewing condylar fractures. Most common surgery for mandibular augmentation or advancement in a skeletal class 2 patient? Bilateral sagittal split osteotomy. Bilateral sagittal split osteotomy. A bilateral sagittal split osteotomy can be used either to advance a mandible or to pull back a mandible. So it can be used for class 2 or class 3. What is the worst complication of bilateral sagittal split osteotomy? Damage of the inferior alveolar nerve with causing paresthesia. How do you fix a skeletal class 3? You can do a Feb10, and you can do a bilateral sagittal split osteotomy or a combination of both. How long do you split after bilateral sagittal split osteotomy? 4 to 6 weeks. What is the most common maxillary surgery? Feb1. Maxillary surgery, Feb1. Difference between distraction osteogenesis and regular osteotomy. Distraction osteotomy cannot retract the mandible. It's not for retracting mandible. Why use distraction osteotomy over the surgeries? Because there's more stability during wide span movements. And distraction osteotomy is used to reconstruct skeletal deformity